Good morning, students. Our today's class is on the gross anatomy of uterus part 2nd. Learning objectives for my today's class are: at the end of this session, students should be able to describe supports of uterus, enumerate and differentiate between true and false supports of uterus. They should be able to enumerate and describe various ligaments of uterus. They should be also able to explain anatomical basis of hysteriosalpingography and tubectomy. Explain the anatomical basis of uterine prolapse. MCQs given at the end of the session will cover dissection part of uterus. Supports of the uterus are divided into primary supporters. Primary supporters include muscular or active supporters, pelvic diaphragm, perineal body. Fibromuscular or mechanical supporters includes uterine axis, tubocervical ligament, transverse cervical ligament of McEnroe's, Uterosacral ligament, and round ligament. The secondary supports of the uterus are of doubtful value and are formed by peritoneal ligaments, which include broad ligament, vesicouterine pouch and fold of peritoneum, rectovaginal pouch and fold of peritoneum. Pelvic diaphragm, as shown in this figure, is formed by levator ani muscle. The gaps or deficiencies are produced by anal, urethral, and vaginal openings. These openings from posterior to anterior are anal, vaginal, and urethral. The deficiencies produced by these openings are supplemented by urogenital diaphragm inferiorly, as shown by these red arrows. They supplement the deficiencies produced by these three openings in the pelvic floor. The true uterine supporters you can see in this longitudinal section are uterosacral ligament, round ligament of the uterus, urogenital diaphragm, rectouterine fold or posterior ligament of peritoneum. It consists of peritoneum reflected from the posterior vaginal fornix onto the front of the rectum, thereby forming the deep recto-uterine pouch. It is bounded anteriorly by the uterus, supravaginal cervix, and posterior vaginal fornix. Posteriorly, it is bounded by a rectum. Laterally, it is bounded by uterosacral ligaments. The broad ligament. Broad ligament is attached to the lateral borders of the uterus, extend one from each side of the uterus to the lateral walls of the pelvis, where they become continuous with the peritoneum. The upper border is free, the lower border is continuous with the peritoneum over the bladder, rectum, and pelvic side wall. They are continuous with each other at the free edge via uterine fundus and diverge below near the superior surface of levator ani. In the free border on either side lies uterine tube, as shown in this figure. Now, if we take a section of the broad ligament in the coronal plane, broad ligament is shown by this yellow area. In sagittal plane, it is shown that this broad ligament is basically a double layer fold of the peritoneum. It has an anterior layer and a posterior layer. Above, the uterine tube is enclosed between the two layers of broad ligament, and this double layered fold of the broad ligament is called mesosalpinges. The posterior layer of the broad ligament splits to enclose the ovary. It runs from the posterior surface of the broad ligament to the hilum of the ovary, encloses it. It is called the mesoovarium. Running from the sides of this uterus towards the lateral pelvic wall is again a double layered fold of the peritoneum, and this double layered fold of peritoneum, demarcated by this yellow dotted area which encloses the uterus, its body and fundus, runs from there towards the side walls, is part of the broad ligament. The anterior and the posterior layer are continuous over the superior surface of the fundus. The anterior and posterior layers are continuous with each other. Division of pelvic cavity. The attachment of the broad ligament to the lateral borders of the uterus and also to the pelvic wall divides the pelvic cavity into two compartments. One compartment lies anterior to the septum formed by the broad ligament. The uterus and the broad ligament form a septum across the lesser pelvic cavity, dividing it into anterior part containing bladder and a posterior part containing the rectum, the terminal ileum, and part of the sigmoid colon. As shown in this diagram, broad ligament is represented by this transverse line which extends from the sides of the uterus towards the lateral wall, thus dividing the cavity into anterior compartment and posterior compartments. In the anterior compartment lies the urinary bladder, and in the posterior compartment lies a rectum. So anterior relations of the uterus are urinary bladder, and posterior relations of the uterus are rectum. With the bladder empty, the uterus and the broad ligament are inclined forward so that the posterior surface faces up and back, and the anterior surface faces down and forwards. As the bladder fills, the plane of ligament tilts backwards and the free borders become superior so that layers face anteriorly and posteriorly. Posterior view of the broad ligament. If we look at the broad ligament from posterior aspect, what are the various structures we can see? From the posterior aspect, you can see mesosalpingectomy and uterine tubes. Mesosalpingectomy is basically part of the broad ligament which encloses the uterine tubes. As already said, it is double-layered fold of the peritoneum enclosing uterine tubes. Uterine tubes lie between the anterior and posterior layers of the broad ligament. Over the superior border of the uterine tube, these two layers are continuous with each other. Ovarian ligament is a ligament which supports the ovary. It attaches the ovary with the lateral wall of the pelvis. This ligament is enclosed in the posterior layer of the broad ligament. Mesoovarium, as shown by this yellow dotted line. Mesoovarium is part of the broad ligament that encloses the ovary. Mesoovarium originates from the posterior layer of broad ligament, encloses ovary. So ovary is attached to the posterior layer of the broad ligament by double-layered fold of the peritoneum called mesoovarium. Ovarian ligament attaches the ovary with the lateral wall of uterus. It is enclosed in the posterior layer of the broad ligament. Infundibulopelvic ligament or suspensory ligament of the ovary attaches ovary with the lateral pelvic wall. This ligament carries blood vessels of ovary. Broad ligament, mesometrium. Mesometrium is basically the part of the broad ligament attached to the lateral pelvic wall. The part of the broad ligament which attaches lateral border of the uterus with the lateral pelvic wall is called the broad ligament, and the part of it between the ovarian ligament and suspensory ligament of ovary superiorly and lateral border of the uterus is called the mesometrium. Posteriorly, we can also see the ureter crossing inferior to the uterine arteries to enter the trigone of the urinary bladder, which is anteriorly placed. Also seen in the posterior aspect of the broad ligament are uterosacral ligament. These ligaments are important because they give support to the uterus. In addition, lymphaticus through these ligaments pass to the sacral group of lymph nodes from cervix. Let me ask you a question. What are the structures seen on the anterior aspect of the broad ligament in a wet specimen? So anteriorly, there is round ligament of the uterus which is enclosed in the anterior layer of the broad ligament. We can also see the uterine tubes which lie between the anterior and the posterior layers of the broad ligament. And posterior lies the ovary enclosed in the mesoovarium. Mesoovarium forms the mesentery of ovary. Suspensory ligament of the ovary or infundibulopelvic ligament attaches the ovary with the lateral pelvic wall. Ovarian ligament attaches ovary with the lateral wall of the uterus. These structures can be viewed from anterior aspect of uterus and broad ligament. Let us make the description of broad ligament very easy for you. So what is broad ligament? Let me ask you some more questions about the broad ligament. What is broad ligament? What are the layers of the broad ligament? What are various derivatives of the broad ligament? Broad ligament is basically a double-layered fold of the peritoneum which encloses uterus and associated structures between its layers. It has got an anterior layer and a posterior layer, inferior margin and superior margin. Inferior margin is fixed, superior margin is free. Between the anterior and the posterior layers, there is a lot of connective tissue. Now if we see on the broad ligament, so it has got an anterior layer and a posterior layer. Anterior and posterior layers become continuous with each other after enclosing uterine tube and also after passing over fundus of uterus. So uterine tube is enclosed between the two layers of the broad ligament. This double layer fold of broad ligament which encloses the uterine tube is called the mesosalpingectomy. From posterior layer of the broad ligament, a double layer fold encloses the ovary. It extends from the posterior layer to the hilum of the ovary in the form of a double-layered fold and is called the mesoovarium. Anterior layer of the broad ligament also encloses round ligament of uterus. So broad ligament is divided into mesosalpingus, which encloses uterine tube, mesoovarium, double-layered fold of posterior layer of the broad ligament enclosing ovaries, and mesometrium, double-layered fold of the broad ligament, which runs from the lateral borders of the uterus to lateral pelvic walls. It supports the uterus besides covering uterus and its associated structures. Anterior and the posterior layers of mesometrium are continuous with each other, enclosing the fundus of uterus. Infundibulopelvic ligament attaches ovary with the lateral pelvic wall. It carries blood vessels of the ovary. An ovarian ligament attaches the ovary with lateral wall of uterus near the fallopian tubes. The divisions of the broad ligament, as shown in this diagram, in the coronal plane, it is divided into mesosalpingus, mesoovarium, and mesometrium. As already discussed, the yellow area represents the mesometrium, which encloses the uterus, runs from its lateral borders towards the lateral pelvic wall. Mesosalpingus, as shown by this green area, is a double-layered fold of broad ligament which encloses the fallopian tube, and mesoovarium, as shown by this blue area, arises from the posterior layer of the broad ligament and encloses ovary. Mesosalpingus is attached about to the uterine tube and posterior inferiorly to the mesoovarium. Superior-laterally, it is attached to the suspensory ligament of ovary. Medially, it is attached to the ovarian ligament. The pimeri of the tubal infundibulum project from its free lateral end. Between the ovary and the uterine tube, the mesosalpingus contains vascular anastomosis between uterine and ovarian vessels, the epophoron and the paraphoron. The mesoovarium projects from the posterior aspect of the broad ligament, of which it is the smaller part. It is attached to the hilum of the ovary and it carries blood vessels and nerves to the ovary, as shown in this diagram. It is a double-layered fold arising from the posterior layer of broad ligament, encloses the ovary and carries its blood vessels. Mesometrium is the largest part of the broad ligament and extends from the pelvic floor to the ovarian ligament and uterine body. The uterine artery passes between its two peritoneal layers about 1.5 centimeters lateral to the cervix. Uterine artery crosses the ureter shortly after its origin from internal iliac artery. Shown in this diagram, it gives off branch to the that passes superiorly to the uterine tube where it anastomoses with the ovarian artery. Other important contents of the mesometrium are: mesometrium also contains ovarian vessels and nerves within a fibrous suspensory ligament of ovary called infundibulopelvic ligament. The mesometrium also encloses the proximal part of the round ligament of uterus as well as smooth muscle and loose connective tissue. Mesometrium contains ovarian vessels, nerves within a fibrous suspensory ligament of the ovary, as already said, which is called infundibulopelvic ligament. The mesometrium also encloses the proximal parts of the round ligament of uterus, as well as smooth muscle and loose connective tissue. To understand the anatomy of these ligaments, let us go to this diagram. To understand the arrangement of structures, let us give two cuts lateral to the entry of fallopian tubes. One cut medial to the ovary and second cut through the ovary. If we get, in the first cut, the structures which are seen are round ligament of the uterus, which lies anterior, uterine tube, which lies in the middle, and mesometrium. Now, if we give a second cut lateral to the first one, which cuts the ovary also, the structures seen are uterine tube and mesosalpingus, ovary and mesoovarium, and round ligament anteriorly. Types of ligaments. Ligaments of the uterus are divided into true and false ligaments. True ligaments are defined as those ligaments which have a fibrous composition and provide support to the uterus. They include round ligament, uterosacral ligament, cervical, and transverse cervical ligaments. False ligaments of the uterus are basically peritoneal folds, duplicatures of the peritoneum that attach to the body of the uterus but provide minimum or no support to the uterus. False ligaments include uterovesical fold, rectouterine fold, and broad ligament, and others only consists of folds of peritoneum. True ligaments of the uterus, if we go to this section of the pelvic cavity, include a pair of round ligaments, a pair of uterosacral ligaments, a pair of transverse cervical and pubocervical ligaments. Round ligament of the uterus. It is also called a ligamentum teres uteri or ligamentum rotundum. They are narrow, somewhat flattened bands 10 to 12 centimeters long, which pass diagonally down and laterally within the mesometrium from upper part of the uterus to the pelvic floor. They are attached superiorly to the uterine wall, just below and anterior to the lateral cornu. The round ligament enters the deep inguinal ring. It traverses the inguinal canal and finally splits into strands that merge with surrounding connective tissue, terminating mons pubis above the labia majora. In this diagram, we can see the contents of the round ligament. The round ligament, besides providing support to the uterus, is also important because it contains important structures. Near the uterus, the round ligament contains much smooth muscle, but this gradually diminishes until the terminal part is purely fibrous. It contains blood vessels, nerves, and lymphatics. During hysterectomy, ligature of this round ligament is important, otherwise it may lead to bleeding. The lymphatics are important because the angles of the uterus, they drain to the superficial inguinal group of lymph nodes through the round ligament. So malignancies from this region can present in the superficial inguinal group of lymph nodes. These lymphatics drain the region around the entry of the uterine tubes to the superficial inguinal lymph nodes. Uterine neoplasms may spread by this route from uterus to the superficial inguinal group of lymph nodes. What are uterosacral ligaments? So as the name implies, they extend from uterus to the sacrum. Again, all ligaments are paired. The uterosacral ligaments are rectouterine folds and contain fibrous tissue and smooth muscle, thus qualifying as a true ligament. They pass back from the cervix and uterine body on both sides of the rectum and are attached to the front of the sacrum. The ligaments can be palpated laterally on rectal examination. On vaginal examination, they can be felt as thick bands of tissue passing downwards on both sides of the posterior fornix. In addition, supporting the uterus, these ligaments also carry lymphatics from cervix to the sacral group of lymph nodes. As shown in this diagram, paired uterosacral ligaments extend from cervix to the pelvic surface of the sacrum. Transverse cervical ligaments, also called cardinal ligaments or ligaments of McEnroe, extend from the side of the cervix and lateral fornix of the vagina to attach extensively on the pelvic wall. As shown in this diagram, at the level of cervix, some fibers interdigitate with the fibers of uterosacral ligament. They are continuous with the fibrous tissue around the lower parts of the ureters and pelvic blood vessels. As shown in this diagram, they extend from the cervix to the lateral pelvic wall. Pubocervical ligaments. Fibers of pubocervical ligament pass forwards from the anterior aspect of the cervix and upper vagina to diverge around the urethra. These fibers attach to the posterior aspect of the pubic bones. As shown in this diagram, these fibers pass from cervix to posterior aspect of the pubic bones, enclosing bladder in between. Failure of uterine support. Now already said the major support of this uterus is from primary supports of the uterus are pelvic diaphragm and also various true ligaments attached to it. Occasionally the musculature and ligament support of the uterus fails, which results in prolapse. Let me ask you a question. What is the prolapse of uterus and what are the underlying anatomical causes for prolapse of the uterus? As already said, uterus is supported by pelvic diaphragm and various ligaments attached to it. Occasionally, the muscular and the ligament support of the uterus fails. In most extreme example, procedentia, it prolapses all the way through vagina. This is called complete prolapse. Uterine prolapse usually occurs in association with prolapse of other organs which are located anteriorly and posteriorly. Anteriorly located is urinary bladder. If there occurs prolapse of the urinary bladder, it is called cystocele, and prolapse of the rectum is called rectocele. It is more common in women who have gone through childbirth and is the result of successive weakening of the pelvic floor during parturition. There is also an inherited component to the pelvic prolapse. Now coming to the applied anatomy. Now let us discuss the applied anatomy of the uterus and its associated structure. Copper is inserted inside the uterine cavity as a temporary method of contraception. Lower segment cesarean section. A transverse incision is given in lower uterine segment using extraperitoneal approach to take out baby in cases where vaginal delivery is contraindicated. Tubectomy or salpingectomy. Tubal sterilization is a surgical procedure that refers to blocking of the female fallopian tubes preventing the eggs from reaching the uterus for implantation. A surgical cut is given in the fallopian tube, dividing it and then ligating cut ends, or simply a band is applied to fallopian tube which blocks it. In this figure, it is shown that superiorly uterine tubes are intact. The eggs go from ovary through uterine tubes while sperms come from vagina, enter the uterine tubes, and fertilization takes place there. The basic method is we give a cut to the uterine tube to prevent the interaction between the sperm and egg. The various methods are we either give a cut in the fallopian tube, then ligate the two cut ends, or we divide the fallopian tube by a cautery, thus separating the two ends. Third method is we apply a band to the fallopian tube, thus blocking its patency. Uterine prolapse. In this condition, uterus descends towards or into vagina due to weakness of the pelvic floor musculature and ligaments which no longer are able to support the uterus. In some cases, uterus may protrude out of the vagina, and this condition is called procedentia. What is hysteriosalpingography? It is a radiological procedure to visualize interior of the uterine cavity and to see patency of the uterine tubes. Indication is sterility. Procedure. A cannula is inserted inside the cervical canal and a radio-opaque dye, usually lipiodol, is injected. About 6 ml of this dye are injected through the internal arch. The cannula does not allow dye to enter the vagina but to pass superiorly into the uterine cavity. An anterior-posterior film is obtained. What we will get on the anterior-posterior film? The dye which we have injected into the uterine cavity, if both tubes are patent, it fills the uterine cavity, then passes through the fallopian tube and supples into peritoneal cavity. After taking an X-ray, we see the dye in the uterine cavity, fallopian tubes, and also it is supple in the peritoneal cavity. This occurs when the uterine cavity is normal, when the fallopian tubes are patent. Bilateral peritoneal supple of the contrast medium is a sign of patency of the tubes. Uterine cavity shadow appears triangular with apex towards the pelvis. This is because of the fact the dye which we have injected is radio opaque. However, if the tubes are not patent, the dye does not supple into the peritoneal cavity, or if there is a unilateral block of the uterine tubes, we can see it on the X-ray film. As shown in this diagram, a dye enters in the uterine cavity. On the right side, it enters the pelvic cavity. On the left side, due to blockage of the tube, dye does not enter into the peritoneal cavity. Now, if both the tubes are blocked, fertilization is not possible. As shown in this diagram, this triangular area represents uterine cavity. On the right side, there is supple into peritoneal cavity. On the left side, dye has not entered into peritoneal cavity. This means the left uterine tube is blocked. As shown in this diagram, triangular uterine cavity, right tube and left tube are shown in this diagram. As normal hysterosalpingogram, smooth triangular uterine cavity and supple from the ends of the tubes on the right and left side. Hysterosalpingogram showing a normal uterus and blocked tubes, no supple of dye is seen at the uterine tubes. Again, we can see the ends of the uterine tubes, but there is no supple of the dye into peritoneal cavity. This means in this case, the uterine tubes are blocked. Dye is inside the uterine cavity. We can see the uterine tubes and its ends, but dye does not enter the peritoneal cavity, meaning that these tubes are blocked. Ultrasound is not now commonly used to measure the dimensions of the uterus, visualize endo, myo, and perimetrium. Use of ultrasound in studying the pelvic anatomy. Our department is also taking classes on ultrasound for the student to make them understand anatomy of the solid viscera. Ultrasound is used to measure dimensions of the uterus, visualize endo, myo, and perimetrium. It is also used to look normally placed and displaced intrauterine contraceptive devices within the uterus. besides fluid collections in the pouch of Douglas can be picked up using ultrasound. Now let us go for a quiz based on this lecture. You will be provided an MCQ with 4 options. You have to choose the most accurate one. Our first question is follow statement about non-pregnant uterus is. It is pear-shaped, lies in the lesser pelvis, weighs 30 to 40 grams, normally retroverted and retroflexed in position. So normally it is antiverted and antifluxed in position. So choice D is wrong. Our second question is while keeping wet specimen of uterus in normal anatomical position, which of the following factors is not important? This MCQ I have framed to make you understand how to keep a wet specimen of uterus in normal anatomical position. Our first choice is ovarian ligament lies posterior inferior, round ligament lies anterior inferior, uterine tube lies between round and ovarian ligament. D is ovarian ligament lies posterior superior in position. As already discussed in the lecture, a wet specimen of the uterus has anterior and posterior surfaces. It is not antiverted and antifluxed as you see in living anatomy. So its surfaces are anterior and posterior surface, not anterior superior and anterior inferior. So the arrangement of the structures at the angles of this uterus are anterior inferior is the round ligament, posterior inferior is ovarian ligament, and in between the two superiorly lies uterine tube. While keeping wet specimen of uterus in normal anatomical position, which of the following factors is not important? Whole of the posterior surface is covered by the peritoneum. It is true. Round ligament lies anterior inferior. Over anterior surface of uterus peritoneum is reflected at the level of internal os. True. Ovarian ligament lies posterior superior in this position. So ovarian ligament lies posterior superior in this position is the wrong option. Which of the following statement is not true about isthmus of the cervix? Constitutes upper third of the cervix. It is true. Undergoes cyclic changes in menstruation. It is true, though these changes are not marked. Forms lower uterine segment. This is also true. After pregnancy, takes part in formation of the lower uterine segment. Forms upper fourth of the cervix. No, it forms the upper one third of the cervix of a non-pregnant uterus. So D is wrong option. Which of the following is not a true support of the uterus? Round ligament. B is uterosacral ligament. C transverse cervical ligament. D is broad ligament. Out of these ligaments, only broad ligament represents a double layered fold of the peritoneum. It is not a true support of the uterus. Which of the following is not a true statement about pelvic diaphragm? Formed by levator ani? True. Three deficiencies from posterior to anterior are rectal, vaginal, and urethral openings. True. Deficiencies are not supplemented by urogenital diaphragm. It supports uterus. So the C is wrong. Deficiencies are not supplemented by urogenital diaphragm. So one of the important roles of the urogenital diaphragm is it supplements the deficiencies produced by the three openings in the floor of the uterus. Which of the following statements is not true about broad ligament? It is a double layered fold of the peritoneum. True. Its inferior margin is fixed and superior margin is free. True. It has an anterior and posterior layers. True. Mesoovarium is derived from its anterior layer is the false statement. It is in fact derived from the posterior layer of the broad ligament. Which of the following is not as content of the broad ligament? Round ligament, ovary, uterine tube, pubocervical ligament. Pubocervical ligament is not a content of the broad ligament. Which of the following is the mean arterial supply of the gravid uterus? Uterine, ovarian, both, uterine, ovarian, and vaginal. It has been shown beyond doubt that the dominant role during pregnancy is played by the uterine artery. Its role during the pregnancy is indicated by its tortuosity, which supplies the uterine wall. Our next question is based on the identification of various structures in the broad ligament. In this MCQ has been made to help you identification of the structures in dissection hall. A is ureter, B is ovarian ligament, D is internal iliac artery, and C is uterine artery. Out of these, choice B, ovarian ligament is wrong. It is not ovarian ligament, it is the round ligament. Again, we will go to the arrangement of structures at the angles of the uterus. So uterine tube lies in the middle. Anteriorly, there is round ligament of the uterus, and posteriorly, there is ovarian ligament. Our next question is false statement about arrangement of structures around entry of uterine tube into uterus in a wet anatomical specimen is ovarian ligament lies posterior superior, uterine tube lies in the middle, round ligament lies anterior inferior. This arrangement helps us in site determination of wet specimen. As already discussed, ovarian ligament lies posterior superior is the wrong option. False statement about a relation between uterine vessels and ureter is A. Uterine arch passes superior to ureter. Uterine vein passes inferior to the ureter. C. Ureter passes below the uterine vessels. D. Ureter may be ligated or cut during hysterectomy. The choice B is wrong. Both uterine artery and uterine vein pass superior to the ureter. False statement about innervation of the uterus is sympathetic nerves are derived from lower thoracic and upper lumbar segments. B. Parasympathetic nerves are derived from S2, 3, and 4 segments. C. Sympathetic nerves cause uterine contraction and vasoconstriction. D. Parasympathetic supply causes uterine contraction and vasodilatation. So D is the wrong answer. Like, subscribe and share this video. Thank you for watching this video.
Do not forget to subscribe my channel. Press on the bell icon to remain updated about more video uploads.